to our master class. Now, I request Dr. R.N. Sekhar, who is also one of our course directors, to introduce chairperson. And chairperson then will introduce our speaker and start the session. Dr. Sekhar, please.
Good morning, everybody, and to my colleagues and the postgraduates. Now, I have a pleasant duty to perform. I'll be calling our beloved chairman, Professor Harishankar Pathak, and today's topic will be a very interesting topic, which will be delivered by Sekhar Chakraborty. He is a consultant physician and nephrologist attached to North Bengal Medical College, Siliguri. Hari, please start your proceeding. Harishankar Pathak, please introduce the speaker. Hari, কি হলো? অমলদা মিউট হয়ে গেছেন। হ্যালো,
ডক্টর পাঠক আছেন? ডক্টর পাঠক,
তাহলে কি
হরিশঙ্কর পাঠক, আপনি হরি বলো, তোমাকে এখানে কিন্তু আনমিউটেড দেখাচ্ছে।
না, মিউটেড,
আনমিউট করতে হবে।
না, আনমিউটেড, হি ইজ আনমিউটেড, এখানে তাই দেখাচ্ছে। হরি কথা শোনা যাচ্ছে না।
কৌশিক, ওকে কোশ কর।
ঠিক আছে, হরি তোমার কথা শোনা যাচ্ছে না। এনিওয়ে, I request, since there is some audio problem with হরি, তুমি শুনতে পাচ্ছ, কথা বলতে পারছো? Anyway, let us start the proceeding. I request our Sekhar, তুই unmute কর, Sekhar unmute করো, Sekhar unmute করো। You start the session. Sekhar, you please start the session.
Respected chairperson and senior teachers and all stalwarts of API. For the want of time, I am not mentioning the name, but all seniors, my seniors, I am very much delighted to express my gratitude. And I have been privileged to talk on a very important topic in clinical practice, that is sodium and potassium imbalance. So, you know that these two particular cations, which are very important physiologically and pathologically in our day-to-day cellular and metabolic activities. In fact, these two cations, one is very much abundant in extracellular fluid like sodium, and one is very abundant in the intracellular fluid like potassium, and its interplay is very important for the clinicians as well as the critical care practitioners. Now, my topic will encompass four aspects. One is hyponatremia, another is hypernatremia, one is hypokalemia, another is hyperkalemia. I think I am audible to all of you?
Audible.
Yes. So now the hyponatremia is defined as a sodium less than 135 millimole per liter. And you know that the different kinds of hyponatremia which we encounter in our clinical practice is better represented as 4 types. Hypotonic hyponatremia, it is rather than volume, tonicity should be mentioned. where the plasma osmolality less than 280 and the sodium is low, which is a very common hyponatremia we encounter in our clinical practice. Another is hypertonic hyponatremia, which is where the plasma osmolality is high in more than 290 milliosmol per kg water, and also the sodium concentration is low. And this is often we find in hyperglycemia, different kinds of diabetic patients, and intravenous immunoglobulin infusion. Another issue is isotonic hyponatremia, where the plasma osmolality is normal, but the sodium concentration is low. And this is basically due to the post-urological and gynecological surgeries, where due to absorptions of the sodium-free water irrigation solutions such as mannitol, sorbitol, glycerin like this. A very important issue is pseudo hyponatremia, which is basically rare, but it can be detected by measuring the sodium by direct ion sensitive electrode. And it is often, we find in hypertriglyceridemia, high protein like paraproteinemia, and obstructive jaundice due to high lipoprotein X. So tonicity is determined by the effective osmoles. Now, plasma tonicity, we derive like 2 into sodium millimole per glucose. Now, this is one important is osmolar. Important to understand that these patients should not be infused sodium, but you must calculate corrected sodium, and you need to understand the importance of pseudo hyponatremia. Now, of which the hypotonic hyponatremia is very common, which can be again classified according to the volume, like hypovolemia, of which the renal and extrarenal causes are important, like diuretics therapy, mineralocorticoid deficiency, and extrarenal like GI loss, skin loss, and bleeding. There might be hyponatremia with euvolemia, where the SIADH is the most important, and as well as hypothyroidism and adrenal insufficiency. Hyponatremia may be associated hypervolemia, which is also a hypotonic hyponatremia, where you'll find different organ failures like heart failure, liver failure, nephrotic syndrome, acute kidney injury, and also the primary polydipsia. Now, you know that the different causes of SIADH, I am not going to detail, but very important, if we find an hypoosmolar state, then how to approach in a hypoosmolar state and what is the clinical outcome. Usually the clinical outcome, when there is a normal brain, it tries to adapt, and we'll find that a normal or low brain or cranial vault ratio, we find an asymptomatic hyponatremia. When there is an adaptation, you will find a different type of symptomatic cerebral edema, and also we can get a hypercapnic respiratory failure. So usually, with regards to the clinical features of hyponatremia, it can be divided into 3 important categories, where the mild hyponatremia means it is between 130 to 134. Moderate hyponatremia means between 125 to 129. And profound severe hyponatremia means less than 125. And again, on the temporal profile, hyponatremia can be divided into acute when the history is less than 48 hours and chronic hyponatremia where the history more than 48 hours duration. Now, clinical features in a nutshell, large number of the patients remain asymptomatic. In the symptomatic group, there is some lethargy and drowsiness, intellectual problem, and in case of severely symptomatic patients, there might be hyponatremic encephalopathy in the form of seizures and coma like this. Now, this is in a nutshell is a diagnostic approach of hyponatremia. If the patient has got a sodium level is less, then we should measure the serum osmolality first. If it is more than 280, then translocational hyponatremia is usually the cause. If it is less than 280 and it is easy to measure the serum osmolality, then we should measure the urine osmolality. When it is less than 100 of urine osmolality means some water intoxication like psychogenic polydipsia is the cause. When the osmolality, urine osmolality is more than 100, then we have to consider whether I am dealing with an edematous state like ascites or not. If there is an edematous state, obviously the congestive cardiac failure, cirrhosis or renal failure. If there is no edematous state, then question of volume depletion comes. Then we should measure the urinary sodium. If the urinary sodium is less than 25, usually the extrarenal causes. If it is more than 25, then diuretics and mineralocorticoid deficiency are the commonest cause. If there is no volume depletion, then renal failure, hypothyroidism, glucocorticoid deficiency, postoperative pressure ventilation, all these. And if we don't detect, then again we should go measure the urinary sodium and then we can repeat the algorithm. So this is the way the hyponatremia we should approach, and then I will quickly cite 2 to 3 cases. A 73-year-old man underwent a left hip reduction internal fixation after a fall at home. Postoperatively, he was started with the IV fluid with a 5% dextrose, 100 ml per hour. He became lethargic on 3rd postoperative day. Chemistry profile shown, creatinine 1.4, sodium 124, potassium 3.3. What is the etiology of this particular case? It suggests that this is a very common scenario. And in this case, 5% dextrose administration, which should not be done in postoperative period. Often the surgeon do this in immediate postoperative period and patient land up in this situation. And here the fluid should be given 0.9% sodium chloride, hypotonic solution should be avoided. Another case, a 40-year-old lady with a liver cirrhosis with type 2 hepatitis infection, presents with a lab findings like sodium 128, potassium 4.4, creatinine 1.2, serum osmolality 285, urine osmolality 500, urine sodium 33, total protein is 12, albumin 2.6. So what is the etiology of this particular case? Here is the case is not an SIADH because the patient is not hypoosmolar. Here the serum osmolality is 285. And this is an example of the pseudo hyponatremia due to hyperglycemic in case of hepatitis C. Third case, a 50-year-old man presents with a hyponatremia with a subarachnoid hemorrhage. This is very common scenario. The sodium 122, serum osmolality 255, urine sodium 82, urine osmolality 445, supine BP 105 upon 62, and sitting BP 90. So the patient is having postural hypotension. What is the etiology in this hyponatremia? This is basically a combination of SIDH and salt wasting syndrome. So cerebral salt wasting. Another scenario is 80-year-old man with a body weight of 56 kg. Patient was put on 25 milligram chlorthalidone for the management of hypertension. Initial electrolytes were normal. 1 month later, she attended emergency with a nausea, vomiting, with a viral gastroenteritis. Laboratory findings showed sodium 118, potassium 2.3, osmolality, serum 253, urine sodium 20, potassium 22, urine osmolar 254. How would you manage this case? This patient has a severe hyponatremia with hypokalemia. In that case, very interesting to understand that we should correct both potassium and sodium, because potassium correction raises the sodium, and that should be taken into account. And this is the formula by which, if you active seizures and respiratory failure. When there is an hyponatremic encephalopathy, seizures are not active, then slowly sodium to be infused like 1 ml per kg body weight per hour through infusion pump, and check the sodium every 2 hours. The patient becomes symptom free. Then if the patient is asymptomatic hyponatremia, very important is fluid restriction, and might be demeclocycline and tolvaptan might be the choice. So these are the all about the hyponatremia. Now coming to an important issue, which is hypernatremia. So it is a definition is defined as when the sodium concentration is more than 145 millimole per liter. And it is basically due to the imbalance of the sodium water intake and the water loss. Access to the water is one of the problem is this. And you know that our total body water intake and loss can be depicted with an internal enteral intake and its outflow as urine and sweat, and also some parenteral intake, and insensible loss is very important. There is also gastrointestinal loss. So total body water is governed by so many factors, and these factors, ultimately alteration of this factor find that the patient might be disoriented, drowsiness, stupor, coma, and ultimately there might be seizures and encephalopathy. So in a nutshell, this is the treatment of the hypernatremia. First one is the correct the intravascular volume, like a sort of 0.9% sodium chloride. And if infused rapidly, in postural hypotension is abolished, jugular vein in the back. Actually, intravascular volume, this first thing is to estimate the water deficit. And we can estimate the water deficit by the serum sodium concentration minus 140 divided by 140 into total body water. And this is usually, say for example, in 80 kg person, usually 5.7. It all depends on the how much hypernatremia is there. So first target is estimate the water deficit, and replacement of the ongoing water losses is very important. And aim of treatment is to decrease the sodium concentration 0.5 to 1 millimole per liter per hour by no more than 15 millimole per liter in first 24 hours. In severe hypernatremia, where the sodium concentration is more than 170, serum sodium should not be corrected below 150 in the first 48 to 72 hours. Now, hypotonic fluid is the choice. Usually, the route of an administration of the fluid is free water through the nasogastric tube or mouth, if the patient can take orally, and other replacement fluid might be 0.5% saline, and glucose containing solutions always should be avoided. Volume should be calculated to reduce the patient's serum sodium by 10 millimole in the first 24 hours is usually required 10 by 140 into 40. That is 2.84 liters of water the fluid required. And this can be administered by drinking water or by through intravenous infusion. And in practice, it is reasonable to give 0.45% saline at the rate of 250 ml per hour, adjusting the rate appropriately and by repeated monitoring. Dextrose solution should be avoided, only to be used as regarded when it is regarded as free water, but the blood sugar should be measured, and monitoring in every 2 to 4 hours is very important. So I'll present here a case, that is case a 72-year-old man was admitted to intensive care unit with a pneumococcal pneumonia. He was intubated and started mechanical ventilation. 3 days later, he was started on enteral nutrition with a 50 ml free water flushes down to NG tube every 6 hours. His sodium gradually raised from 142 to 155 over 3 days. How would you manage this approach to hyponatremia? This is a critically ill patient with no access to the free water, and hyponatremia is commonly encountered in case of enteral nutrition. In fact, you see that when our sisters give the nutrition through nasogastric tube, sufficient oral water is not being given. The first action to increase the free water through NG tube, if it is ineffective, an infusion of 5% dextrose can be started, but better to avoid. Next case is an 85-year-old man with advanced dementia, presented to emergency department from a skilled nursing facility due to obtundation. The sodium was 181. She weighs 56 kg. How would you manage hypernatremia? In fact, first we should calculate the water deficit, which I have mentioned, that current sodium minus 140 divided by 140 multiplied by current total body water. And this the way we should here the 56 kg body weight into 0.5, so 8.2 liters. And it is reasonable to start a dextrose at 150 ml per water and check every 6 hours, avoid lowering sodium by more than 12 millimole per 24 hours. So this is the case 3 discussion regarding primary polydipsia, case 4, and diabetes insipidus. I think I have to skip because of want of time, I think. So coming to the point of hypokalemia, you know that hypokalemia, basically clinicians should understand the potassium homeostasis. And the potassium, you know that the potassium is majorly an intracellular cation, where 98% is in the intracellular fluid, remaining in the muscle, liver, red cells, and interstitial space. Only extracellular fluid is only 2%. And here it is a combination of daily intake, 90% with the urinary fecal excretion, 10% 10 milliequivalent per day of the fecal excretion, and 90 milliequivalent per day of the urinary excretion, and combining two together, the homeostasis is maintained. And there are certain factors which are also play, like different hormones in the form of insulin and beta-2 adrenergic stimulation, as well as acidosis, plasma hyperosmolality, alpha adrenergic stimulation, and exercise. So basically, the urinary sodium excretion is governed by aldosterone and potassium plasma levels, sodium delivery at the level of the DCT, urinary flow, and kidney injury. So all these governing to maintain the potassium homeostasis. Now, so how you define hypokalemia? Hypokalemia, you know that the normal potassium concentration is between 3.5 to 5 up to 5.5 milliequivalent per liter. Hypokalemia is defined when there is an potassium level less than 3.5. Here is a wrongly written 2.5. It is less than 3.5. And severe and life-threatening is less than 2.5. Usual hypokalemia is less than 3.5. In outpatient population, usual incidence is around hypokalemia is a mild. And in fact, mild hypokalemia is the commonest electrolyte abnormality in our clinical practice and is around 14%. But severe hypokalemia may be present and maybe around 4.5% might be clinically significant. There are some, now potassium homeostasis is governed by some internal potassium balance, which is basically a shift from the intracellular fluid to extracellular fluid, and the external potassium balance, which is maintained by excretion of the through urine and some excretion through stool and from some sweat. So these internal potassium balance and external potassium balance need to understand. And internal potassium balance is governed by acid-base status. You know that the acidosis increases the extracellular fluid potassium. Pancreatic hormones like insulin release stimulated by hyperkalemia, and it is inhibited by hypokalemia. It ultimately, it helps to activate the sodium potassium ATPase pump, and that's why the potassium directly enters into the cell. Among the calamines, adrenergic agonists, they promote the cellular potassium uptake by activating the pump via a different mechanism like cyclic AMP dependent mechanism. Alpha adrenergic has got an opposite effect. Exercise, in fact, it has been observed that the serum potassium may increase temporarily by 50% after a 10 to 15 minutes of vigorous exercise, and it can fall precipitously after recovery. Aldosterone is an important for external balance. Osmolality, hyperosmolality increases serum potassium concentration, and total body potassium also governs the plasma potassium. And the factors which actually modify the external balance, that is the distal nephron, of which the most important hormone in aldosterone. You know that I'll show the picture that the aldosterone receptor remains in the basolateral aspect of the distal convoluted tubule, where this aldosterone works, and ultimately it involves the ATP synthesis of the nucleus, and which drives the sodium potassium ATPase pump in the basolateral membrane, which ultimately this pumps out the helps in pumping out the sodium and enters into the potassium into the cell. And this aldosterone helps in excretion of the potassium and conserve sodium. Intravascular volume is very important. We call it a contraction alkalosis. When the patient is dehydrated, there is contraction of the intravascular volume. We find that the patient has got an alkalosis. That's why when you find that the patient has got a pH is high, the first thing you need to understand, the patient should be infused with an isotonic fluid. So volume contraction, this is what is called a contraction alkalosis, you need to understand. Dietary potassium intake is also help in the homeostasis of the potassium. Serum potassium concentration, acid-base testers, urine flow at the level of the distal convoluted tubule is very important. Sodium, reduced delivery of the sodium, in fact, impairs the potassium secretion. This piece of information need to understand why the sodium, low sodium also helps in excretion, leads to hypokalemia. When there is a sodium is low, then there is development of the hypokalemia, because and these and other factors like ADH and poorly absorbable ions. So these are the causes of hypokalemia in the form of altered internal balance, one, and where you'll find that there is an distribution of the potassium between the extracellular fluid and intracellular compartment is disturbed. And in that case, the causes remains like alkalosis and insulin insulin and beta-2 adrenergic stimulants, vitamin B12 deficiencies, intoxications, and sorry. Yes, some periodic paralysis, and also the altered external balance like low total body sodium, like renal losses, when the urinary potassium is more than 20 millimole per day. There might be appropriate renal response to alkalosis, some mineralocorticoid excess. This is very important, like primary hyperaldosteronism, fludrocortisone, different congenital adrenal hyperplasias, renin secreting tumors, Cushing syndrome, and renovascular hypertension, as well as vasculitis. So there is one issue is apparent mineralocorticoid excess, like Liddle syndrome and syndrome of apparent mineralocorticoid excess in the form of hereditary 11 beta hydroxysteroid deficiency. If I find time, I'll discuss this issue. And acquired 11 beta hydroxysteroid deficiency like licorice, chewing tobacco, carbenoxolone. And also there is impaired renal tubular ion transport like diuretics, Barter syndrome, Gitelman syndrome, renal tubular acidosis, high dose penicillins, and magnesium depletion. There might be some extrarenal losses in the form. In that cases, we'll find that the urinary potassium is less than 20. So when the urinary potassium is less than 20 millimole per day, so we should think that there is external loss in the form of gastrointestinal loss and as well as the skin loss. So symptoms of hypokalemia may be divided into two, where the mild to moderate hypokalemia, usually patient might be symptomatic, especially in the elderly people and or the people who are suffering from the kidney or the heart disease, there might be some symptoms. Severe hypokalemia, like renal, if we say organ-wise, if we find that there might be metabolic acidosis, rhabdomyolysis, or hypokalemic kidney disease. So with regards to the nervous system, there might be leg cramps, weakness and paralysis, and might be ascending paralysis. There might be constipation, respiratory failure, and cardiovascular changes in the form of ECG changes like appearance of the T waves and flattening of the T waves, appearance of the U waves and the flattening of the T waves, and some ST segment changes. These are changes of the ECG for hypokalemia, and might be cardiac arrhythmias and heart failure. So this is basically the diagnostic approach, how we should approach for hypokalemia. So first of all, we have to measure that 24 hours urinary potassium excretion. If it is low, then less than 15 millimole per day, then usually the gastrointestinal causes or hypokalemic periodic paralysis is the cause. When the potassium excretion is high, then we have to see whether the patient blood pressure is high or blood pressure is low or normal. If the blood pressure is high, there might be low reninic hypoaldosteronism. This is could be the cause. And in that cases, different syndromes like 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency, apparent mineralocorticoid excess, Liddle syndrome, these Cushing syndrome, and glucocorticoid resistance, this could be the pathology. And if there is a blood pressure high also, there might be an aldosterone renin ratio might be increased. There might be high aldosterone, like in case of primary hyperaldosteronism, adrenal adenoma, and bilateral adrenal hyperplasia. If the blood pressure is normal, then we have to measure the plasma bicarbonate. And if the plasma bicarbonate is low, the cause is usually renal tubular acidosis. But if the plasma bicarbonate is high, then gastric losses, diuretic loss, magnesium deficiency, Barter syndrome, Gitelman syndrome, these could be the causes. So this is the different ways we should understand. And one, I should mention that these three important, 5 important differential diagnoses which come together, like vomiting, diuretic consumption, laxative consumption, which are often remains occult, and renal tubular acidosis and Gitelman syndrome. It is often might be very difficult to, but the important issue which we have to understand that the urinary chloride is the most important thing. If we find that the urinary chloride is normal, then it could be a diuretic consumption or renal tubular acidosis. If the urinary chloride is low, then there is the laxative consumption or there might be vomiting. Urinary chloride is high, then Gentleman syndrome is usually the cause. So urinary chloride is the most important marker by which these 5 differential diagnoses can be easily, and subsequently the serum bicarbonate or plasma bicarbonate is very important, and also the magnesium. This is the important issues. Then there are some rare causes, that the mineralocorticoid excess, there might be a mineralocorticoid excess or apparent mineralocorticoid excess. Means in that case, there is no excess mineralocorticoid secretion, but there might be the receptor stimulation of the mineralocorticoid, or might be apical epithelial sodium channel positive stimulation or stimulation that leads to either in the form of the Liddle syndrome or in the form of disluming mutation of the type 2 11 beta hydroxysteroid dehydrogenase genes, which leads to access to the mineralocorticoid receptor of the cortisol. Now, one important issue that the people usually prescribe leucorides or carbenoxolone, or the people are taking chewing tobacco. You know that this can inhibit the 11 beta HSD. And if there is an inhibition of the 11 beta HSD, there might be a situation may develop where there is an apparent mineralocorticoid excess, and this patient may develop hypokalemia. So always think that those who are prescribing sucralfate and patients are taking chewing tobacco, there is a chance of developing the acquired apparent mineralocorticoid excess syndrome. Renal tubular absorption transport problem, one is very important, is Gentleman syndrome. This is basically NCCT gene mutation, and this mutation leads to this NCCT, that is sodium chloride co-transporter in the distal convoluted tubule, and this leads to hypotension, alkalosis, hypomagnesemia, hypermagnesiuria, and very important is hypocalciuria. So another issue is Barter syndrome. You know that the Barter syndrome, this is Gentleman syndrome, is a disease of the distal convoluted tubule. Barter syndrome is a disease of the loop of Henle, thickened loop of Henle. Here there are the different kinds, but basically this is the sodium potassium 2 chloride transporter defect, and that leads to the Barter syndrome. This picture shows how these thick medullary ascending limb, there's a different kinds of Barter syndrome. If I find time, that I'll discuss the Barter syndrome of the different types. But the distal convoluted tubule disease is a Gentleman syndrome, and the thick ascending limb of Henle, that is medullary thick ascending, is the Barter syndrome. And there is both the cases. There is here is the sodium potassium chloride channel, and there also a sodium chloride co-transporter system. There might be some rare causes of the internal balance in the form of hypotoxic, some periodic paralysis, and there might be thyrotoxic periodic paralysis, sporadic periodic paralysis, hypernatremic hypokalemic periodic paralysis, and familial periodic paralysis. This is one study I have just mentioned, that if 97 patients have been studied, and there are the different types of periodic paralysis we encounter. In fact, it has been observed that thyrotoxic periodic paralysis or hypokalemic periodic paralysis is more common in India and Southeast Asian countries rather than European countries, and of which another particular syndrome has came up, which is basically called sudden cardiac death syndrome. And this is the syndrome which is also called sudden death syndrome during sleep, SUDS. So this is a Thailand and Philippines. Annual incidence is quite high, around 20 per lakhs between 20 to 39 years age group persons. And here the ECG is more or less that of the Brugada syndrome, where there is R2R, RS, R dash pattern and ST segment elevation in V1 to V3. But this is very common, and this has been reported from Thailand and Philippines that during sleep and probably hypokalemia is the reason of this death. I'm not going to detail this one. And this is the treatment of hypokalemia. We can divide into mild hypokalemia like from 3 to 3.5, where the potassium infusion might be there, or oral potassium can be given. Potassium tablets can cause ulceration in the GI, so should not be given. It is the liquid form and should be monitored potassium. Moderate hypokalemia in the form of 2.5 to 2.9 milliequivalent per liter. Potassium infusion like 25 ml or 100 millimole per day is the usual amount of the potassium we infuse. And in case of severe hypokalemia like less than 2.5, then intravenous replacement like 40 millimole potassium in sodium chloride and 0.9%, 1 liter, and glucose 5% may be used also. A standard infusion is 10 millimole per year. Maximum dose is 20, and in usually maximum amount of potassium is around 180 to 240 milli equivalent per 24 hours. So this is the way we work this one. Now coming to hyperkalemia, my last topic, how to approach and manage hyperkalemia. Now I have already mentioned that potassium is an intracellular cation, and our body content of around 3000 to 4000 milli equivalent. And you know that the renal excretion is basically a major route of the potassium elimination. So primary mechanism maintaining this balance is our buffering of the extracellular potassium. Now extracellular potassium may enter into the intracellularly or may be excreted mostly by the urinary route or fecal route or through sweat. So how the homeostasis of the potassium I have mentioned, that of which the sodium potassium pump plays a very important role. And sodium potassium pump activity transports, in fact, sodium out of cell and potassium into the cell at the ratio of 3:2. And this is very important. So this is basically an active pump run by ATP. So this pump is need to understand for homeostasis. Now within kidneys, potassium mostly excretion occurs through the principal cells of the cortical connective CCT. And urinary potassium excretion depends on one is sodium, luminal sodium delivery, which I have mentioned, and also the effect of aldosterone, and also the adrenal corticoids, which have got the mineralocorticoid activity. So this is basically a picture showing the apical cell of the distal convoluted tubule, of which the basolateral aspect has got two important. One is aldosterone receptor, another is sodium potassium ATPase pump. And the luminal side, you will find two important receptors. One is epithelial sodium channel, where the amyloid work, and this aldosterone receptor, which is present in the basolateral aspect, here is the spironolactonates. And in the luminal side also there is a potassium channel, which helps in the excretion of the potassium, and this apical sodium channel is responsible for the conservation of the sodium into the cell. In fact, it is the activity of the sodium potassium pump which drives the absorptions of the sodium from the luminal to intracellularly, then out to the blood. So this is the way the aldosterone sensitive distal nephron works. And this is the different hormones like aldosterone, which decreases, which helps in potassium excretion. Insulin helps into pushing the potassium into the cell. Beta adrenergic agents tries to push the potassium into the cell. Alpha adrenergic agents try to draw the potassium out of the cell. Acidosis try to draw out the potassium from the cell. Alkalosis tries to push the potassium into the cell, and also the cell damage like to draw the potassium out of the cell. So these are the different hormones, and as well as the acidosis and alkalosis, they basically interplay the homeostasis and potassium. So therefore, hyperkalemia is defined when the potassium level is more than 5.5 milliequivalent, and severe hyperkalemia is when the potassium level is more than 6 milliequivalent, and decrease in renal excretion is usually the most important cause. When there is a problem in the renal excretion, then the potassium is locked into the plasma, and that leads to hyperkalemia. Now, you need to understand one thing is a pseudo hyperkalemia, like pseudo hyponatremia I have mentioned, and here most of the problem remaining either in the venipuncture, there is any problem of the muscle activities during venipuncture, or marked cellular damage, sometimes marked cellular elements in the blood like thrombosis, leukocytosis, any erythrocytosis. This situation leads to pseudo hyperkalemia. Cooling of the blood following venipuncture is the another cause. If you so always ask the technician to test the potassium as early as possible. If the blood is drawn at night and left for 12 hours in the fridge and measured in the next morning, then certainly it will cause the hyperkalemia. The result will come to hyperkalemia, and this is basically pseudo hyperkalemia. And the genetic causes causing this is passive sodium permeability across the erythrocytes. So these are the different reasons why there is. So this is the intra to extra cardiac acidosis. I have already mentioned that there is a flux of the potassium out of cell. Hyperosmolality like hypertonic dextrose, mannitol can act as a solvent drag. Beta-2 adrenergic agonists in the form of that suppresses the catecholamine stimulated renin release in turn of aldosterone synthesis. Digoxin and related glycosides, they're very important. They inhibit the sodium potassium ATPase pump. Once they are, the pump is inhibited, so the situation becomes standstill. Sodium remains intercellularly, potassium remains extracellularly. So there might be development of hyperkalemia. So hyperkalemic periodic paralysis is an episodic attack of the muscle weakness. Lysine, arginine, and aminocaproic acid, like potassium, they are positively charged. They can cause succinylcholine. Anesthetist uses this depolarizes muscle cells, can efflux the potassium through acetylcholine receptors. They can cause hyperkalemia, and also rapid tumor lysis and rhabdomyolysis. So there might be inhibition of the renin-angiotensin aldosterone axis that leads to increased potassium level. And when these drugs are used in combination, like AC inhibitors, like renin inhibitors, like aliskiren, there might be ARB. These are in combinations. You all know that lead to, and also blockade of mineralocorticoid receptors like spironolactone and eplerenone. Or there might be blockade of ENaC, which I have shown at the apical of the DCT by amiloride or triamterene, or even trimethoprim and pentamidine, that can cause, in combination, can cause hyperkalemia. There might be decreased distal delivery, and that might be lead to the as an effect of congestive cardiac failure and volume depletion. Hyporeninic hypoaldosteronism and issues where tubulointerstitial disease like SLE, sickle cell anemia can cause, diabetes, and different drugs in combination, of which most notorious is NSAIDs, cyclosporine and tacrolimus, and beta blockers, non-specific beta blockers that can lead to our hyporeninic hypoaldosteronism. And chronic kidney disease and pseudo hypoaldosteronism, these two, one is type 1 and type 2, that leads to like renal resistance and tubulointerstitial disease. And there might be some hereditary causes, which I have mentioned, like pseudo hypoaldosteronism type 1, that is basically a defect in the mineralocorticoid receptor at ENaC level. And this is just the opposite type of disease of Barter syndrome. And sorry. Yeah. Primary hyperaldosteronism, I'm not going to detail this. Pseudo hypoaldosteronism type 1. This is basically, this is opposite to the Little syndrome and autosomal dominant form and mutations affecting the mineralocorticoid receptors. That these are, this is basically the symptoms of hypokalemia. And another issue is pseudo hypoaldosteronism type 2, like Gordon syndrome. Here it is the problem with the sodium chloride co-transporter channel, like in CCT, and symptoms like retention of the sodium and hypertension, volume expansion are the cause. And most of the hypokalemic patients are asymptomatic. Symptoms are usually non-specific. There might be weakness and fatigue. Patients may also complain of palpitations and chest pain. There might be development of the cardiac arrhythmias, may report nausea, vomiting, paresthesia. Ecg findings generally correlate with the potassium level. And you know that the patient might have the organic heart disease as well. This is the usual Ecg finding when the tenting of the T wave or peaked T wave is usually featured in mild hypokalemia. In moderate hypokalemia, along with this tenting of the T waves, there is a loss of the P waves and prolongation of the QRS complex. When there is a severe hypokalemia, when the potassium level more than 8, then progressive widening of the Q waves leads to sine wave, different types of ventricular fibrillations, and bundle branch defects may develop. So is more or less correlate with these ECG findings of hyperkalemia. I have just shown this is the symmetrically tented T waves, tall tented T waves, 3T are features of hyperkalemia. Now sine waves appearance in case of severe hyperkalemia. So last point is diagnostic approach to hyperkalemia. Tests to be done. History is very important. Failure to be identified. Blood urea nitrogen, creatinine and serum osmolarity. Serum electrolytes, magnesium, calcium. Urine, potassium, sodium osmolarity, complete blood count and ECG. Transtubular TTKG, I am not going to detail, but the very important is that when there is an hyperkalemia, you check whether there is ECG changes or not, or the potassium level more than 6, it is an emergency therapy. Simultaneously, you exclude pseudo hypokalemia. If there is pseudo hyperkalemia, no further action is required. If there is no ECG changes, and then you gradually take the history, physical examination, and evidence of the increased potassium load, identify and evaluate accordingly. And then obviously you should ask for there is any transcellular shift of potassium, identify it and treat accordingly. When there is decreased potassium excretion, think and there might be some hypertonicity and hyperglycemia like this. So these are then you have to identify the urinary electrolyte. Accordingly, you have to measure the TTKG, and when the TTKG is high, then reduced tubular flow might be there due to the advanced kidney failure or reduced extracellular volume. When the TTKG is low, like less than 5, then the patient is put on 9-alpha hydrocortisone. And then the TTKG, if it is still remains low, there might be some drugs. When the TTKG is high, there might be low aldosterone renin issues, and renin might be low and high. Accordingly, you have to identify. 3 main approaches for treatment: antagonizing the membrane effects of the potassium by calcium, as well as driving extracellular potassium into the cells, removing excess potassium from the body, and immediately to be given IV calcium, immediate antagonism for the cardiac effects, which is very important to understand that IV potassium is the first drug to be given 10 ml, 10% calcium gluconate, slowly over the period of 10 minutes with cardiac monitoring. Effects usually within 1 to 3 minutes and last for 6 minutes. Dose should be repeated if there is no change. Rapid reductions of the potassium can be done by insulin, dextrose insulin solution, 10 units regular insulin, with a 50 cc, 25% dextrose to be given over 60 minutes. bolus regimen is usually given. Glucose concentration, if it is more than 200, insulin should be given without glucose with a blood glucose monitoring. Now, it reaches its peak by 90 minutes, usually lasts for 2 to 6 hours, and recommended dose of, I'm talking about beta-2 agonists, and albuterol is usually 10 to 20 milligram is given in 4 ml of normal saline over 10 minutes. Effect starts immediately within 30 minutes. Cation exchange resin, this is a very slow acting drug, and usually the SPS 15 to 30 gram of powder is usually given in 33% sorbitol. Potassium concentration is slow and full effect may take up to 24 hours. And the sodium bicarbonate may be given. Reversible causes to be identified. Loop diuretics and the thiazide diuretics are also the therapy. And the most definitive therapy is hemodialysis. Amount of potassium to be removed during hemodialysis. The relative distribution of the potassium between ICF and ECF to be done. And its success depends on the type and surface of dialyzer used and dialysate under blood flow rates. And dialysis duration and the plasma to dialysate potassium gradient. Thank you very much.
Can be obtained from API office. One question from big host: when should 3% sodium chloride be used for correction of hyponatremia? This is a very simple question.
Yes, 3% sodium chloride is, it all depends. 3% sodium chloride required for, if there is a mild sort of hyponatremia, then 3% sodium chloride is not required. So only some amount of the fluid restrictions and usual sodium intake, or sodium might be added to salt. But 3% sodium chloride is required for in case of severe hyponatremia. And and the infusion depends on whether it is acute or chronic. Among the acute, whether it is developed within 48 hours means acute, and what is the tempo of the disease. Over the period of 8 to 12 hours, very slowly, almost 1 ml per kg per hour, 1 ml per kg per hour. So this is the usual. And when you infuse, then it is usually 3 ml per kg per hour in a bolus, and maintenance by 1 ml per kg per hour. So this is the way the sodium to be infused. And before infusing the sodium, you must calculate the deficit, because ultimately how much sodium you have to give, that will dictate.
From Anamika Bhadro: how vitamin B12 therapy causes hypokalemia?
Actually, vitamin B12 therapy ultimately cause is not known, but the proposition is that again these changes are is related to some aldosterone effect. So there might be some excess secretions of the aldosterone that lead to the potassium wasting and ultimately leads to hypokalemia. But the cause is not known why the vitamin B12 causes hypokalemia.
A few comments from my side. What is the role of serum magnesium in the management of hypokalemia?
actually, the thing is that serum magnesium works together with serum potassium. In fact, though the potassium is a single cation and the magnesium has two double, valency, but the thing, these two cations work together. And what we commonly find that when there is a severe hypokalemia and the severe hypokalemia is not corrected, in spite of giving the sufficient amount of potassium intravenously, then we think that whether there is magnesium deficiency is not, whether there is magnesium deficiency, there is not. Then, interestingly, when we give the magnesium and we maintain if we find that the magnesium level is low, and if we infuse magnesium, then very easily the potassium is corrected. So therefore, this is the way the potassium level is stabilized. In fact, magnesium helps in excretion of the potassium in the body. So to maintain the potassium level, magnesium helps. It prevents its excretion. Prevents its excretion to the urine.
From Souvik Das, in a case of hypernatremia, if a case of hypernatremia comes with severe metabolic acidosis, how should we use sodium bicarbonate?
It's a good question. In case of, the thing is that in case of severe metabolic acidosis, it actually requires the sodium chloride. Sodium bicarbonate. The thing is that in one hand, you have to give the sodium bicarbonate. But now the potassium bicarbonate is also available. So you can use the potassium bicarbonate, but it is not very commonly available. If you have to give the sodium bicarbonate infusion, then simultaneously you have to give the free water. And this is a very critical state where there is an hypernatremia with an metabolic acidosis. And here, certainly in that case also, there's the potassium level is high. These patients need urgent dialysis. You have to put the patient on dialysis, remove the acid from the body, remove the potassium. But the problem is that with the dialysis, patient may land up in a situation of a hypovolemic situation, which can increase the sodium level. So therefore, you have to have an hemofiltration rather than loss. You have to have a hemofiltration over the period of time where the volume is maintained, or you can infuse the volume and you take out the acid and as well as the potassium. This is the best way to treat this critically ill patient. But if you don't have the access to dialysis, then you have to take the measured step. Intravenously, you have to give the sodium bicarbonate as well as the free water through nasogastric tube. And the free water of the nasogastric tube volume would be much more than the amount of the sodium.
One question rather or comment from my side. In case of hyperkalemia, hypokalemia, we get ECG changes. But why don't get any ECG changes during disturbances of sodium metabolism? That is hypernatremia or hyponatremia.
Yeah, that is a very good question, because you see that the ECG changes if you look carefully the membrane potential of the cardiomyocytes. You see that the sodium channel opens first, and that leads to the action potential. And this is the only opening of the sodium channel that is required, and subsequently it is maintained by potassium and calcium channels. The thing is that sodium is an extracellular fluid, and in our body there is abundant amount of the sodium remains. And as the cardiac myocytes is the syncytium, here the sodium is not play a major role. Just the opening of the sodium channels of the action potential, sodium has got a role. But the sodium has got a major role in transmission of the action potential in the nerves. That's why the nerves are commonly affected with a sodium alteration like hypokalemia and hypernatremia. We find more neurological features in hypokalemia and hypernatremia. But the membrane potassium is relatively insensitive to sodium, and it is very sensitive to the potassium. So that's why the ECG, as this ECG is a reflection of the membrane potential of the cardiomyocyte, so that's why the ECG manifestations is obvious in the potassium, not in sodium. But the neurological changes are more obvious in sodium.
So, Dr. Sekhar Chakraborty has nicely covered the topic in a very nice way. For the information of participants, we could not mention earlier that Dr. Chakraborty is one of the examiners in the MRCP clinical part, and he was awarded just last year this Chikitsak Ratna, I think, the highest, yeah, the highest award accorded by West Bengal government.
In health sector.
So with this, I am now handing over to probably Professor S.B. Ganguly, I think.
Okay.
Professor Sekhar.
Okay. Thank you, Dr. Harishankar Pathak and Sekhar Chakraborty. Now I request Dr. S.B. Ganguly, who is also one of our course directors, to give thanks, vote of thanks to both chairperson and also the speaker.
Sekhar Jyotirmoy, Sekhar, excellent. Amit, with your permission, I am putting the recording in GimaTube so that all over India can read your.
Okay. Shotto Ganguly is here.
Okay, thank you.
Shotto, you please give thanks.
Yes, now I have a pleasant duty to give thanks. First, I give thanks to my brother, Dr. Sekhar Chakraborty, and wonderful presentation of a very difficult but very important subject, which is our day-to-day problem. I think PGT will be immensely benefited by this lecture, and Jyotirmoy told that it will be in the YouTube, so they can see it after. My also sincere thanks to Professor H.S. Pathak for his beautiful summing up and chairing the session, and to all the participants of this masterclass, especially the PGT, for which we are performing this type of masterclass on every Sunday. Hope you will meet in the next Sunday. For this week,
Thank you, Dr. Ganguly, for your giving thanks. Now we are going to adjourn the session, masterclass session. Next week, next Sunday, that is 27th of June, we are approach to dementia. All are requested to assemble sharply by 11:28, 27th June. Thank you. Now we adjourn this masterclass session. Thank you.
Thank you.